Hello everybody, and thank you for joining me in this short video presentation on wide QRS complex tachycardia. A wide QRS complex refers to a QRS complex duration equal or more than 120 milliseconds. Widening of the QRS complex is related to a slower spread of ventricular depolarization, either due to disease of the His-Purkinje network and or reliance on a slower muscle-to-muscle spread of depolarization. The wide QRS complex tachycardia can be seen during propagation of a supraventricular impulse with preexisting or rate-related block in one or more parts of the His-Purkinje network, or depolarizations originating in the ventricles themselves, like ventricular premature beats or ventricular tachycardia, slowed propagation of a supraventricular impulse because of intramyocardial scar fibrosis or hypertrophy, and last but not least, conduction of a supraventricular impulse from atrium to ventricle over an accessory pathway. This is a 70-year-old man with anterior wall myocardial infarction many years ago and severe LV dysfunction who was admitted electively for a bypass surgery. On the next slide, we will see the ECG on admission. ECG on admission shows a wide QRS complex tachycardia with a heart rate of 120 beats per minute. What could be the diagnosis? We already saw together that 80% of all wide complex tachycardias are VTs. We have to remember that this patient is older than 35 years old and has a structural heart disease. In patients older than 35, the probability that a wide QRS complex tachycardia is a VT is over 90%, and in the presence of a structural heart disease, the probability is over 93 to 95%. There are other ECG criteria that indicates that this wide QRS complex tachycardia actually is a ventricular tachycardia, and one of them is the QRS duration of this tachycardia, which is around 190 to 200 milliseconds. The other criteria that we see in this ECG are negative concordance in precordial leads, VA dissociation, and QR pattern in lead V1. So in addition to age, underlying structural heart disease, we see in this ECG criteria for diagnosing ventricular tachycardia. In CMR, we see a large apical aneurysm and extensive scar formation in apex and anterior wall. The question is, can we predict ventricular arrhythmia based on imaging data? In the next slide, we will see together an interesting recent study which tried to address this issue. We know that transition zones between healthy myocardium and a scar form a spatially complex substrate that may give rise to reentrant ventricular arrhythmias. The authors sought to assess the utility of a novel machine learning approach for quantifying 3D spatial complexity of grayscale patterns on late gadolinium enhancement cardiac MRI to predict ventricular arrhythmia in patients with ischemic cardiomyopathy. 122 consecutive ischemic cardiomyopathy patients with LV ejection fraction below 35% without prior history of ventricular arrhythmia underwent late gadolinium enhanced CMR images. From the statistical machine learning results, a complexity score ranging from 0 to 1 was calculated for each patient and tested using multivariable Cox regression models. At 5 years of follow-up, 40 patients had ventricular arrhythmia events. The machine learning algorithm classified with 81% overall accuracy and correctly classified 86% of those without ventricular arrhythmias. Overall, negative predictive value was 91%. Average complexity score was significantly higher in patients with ventricular arrhythmia versus those without, and was independently associated with ventricular arrhythmia events in a multivariable model, as we can see here. The authors concluded that incrementally to multiple known risk factors for ventricular arrhythmias like ejection fraction in patients with ischemic cardiomyopathy, substrate spatial complexity analysis of late gadolinium enhanced cardiac MRI images is significantly and independently associated with ventricular arrhythmia events. Thank you for joining me, and I hope to have you here in my future video presentations.